Namaskar. My talk is on pattern hair loss, the current prospective and evidence based treatment update. I am Anil Garg. What do we expect from any therapy? The therapy should be effective to prevent the progression of the disease in terms of AGA, we say it control of miniaturization. Efficacy to improve from existing means the reversal of miniaturization. The drug should be safe. It should be user friendly for the patient as well as for the physician, and there should be scientific evidence of all above. So I have included two guidelines. One is the European Dermatology Forum guideline, another is the Japanese Society Dermatology guidelines. They have done a meta-analysis and based on various studies, evidences, they have given some guideline about the therapy and the various medicines for treatment of androgenetic alopecia or pattern hair loss for male and female both. So how to decide which therapy to recommend based on evidences? The evidence-based assessment. Evidence-based assessment is done for a study. Supposing if you do a study, how good that study is. Accordingly, they are given the grading of A1, A2, B, C and D. So this is for a particular study. But for a particular regime or a medicine, the grading is done 1, 2, 3, 4. And then comes the strength of recommendation based on the level of evidences. Then a group of scientists, physicians or doctors decides upon on all those scientific evidences that particular medicine or regime is recommended, they suggest, can be considered, they do not suggest, they do not recommend, and they cannot make recommendation. So these words you will be listening during my talk. So pathogenesis of pattern hair loss, the exact pathogenesis is still incompletely understood as there is variation in the pattern as well as differences in response to the current modalities of treatment. But it is clear that there is a genetic predisposition and role of androgen in male pattern hair loss. The female pattern hair loss is a more complex etiology. The genetic predisposition with androgen dependent and androgen non-dependent hair loss mechanism works for female. So now we are talking of male pattern hair loss. The pathogenesis, as I said, genetic, yes, it is polygenic, X-linked, and main gene is the AR gene. The androgen testosterone under the effect of 5-alpha reductase converts into DHT, and DHT is the principal causative agent behind this. Genetically predisposed hair follicle falls under the effect of androgen. This is one sentence which we can say for male pattern hair loss. Now the evidences. The monozygotic twins has 80 to 90% concordance rate. Means if one is having, another will have also. Osborne has done the study of autosomal dominant. Polygenic means multiple candidates genes are responsible, but AR gene is mainly. AR gene is located on X chromosome, showing that there is a mother component. There is a higher expression of AR genes in balding scalp, and those who are having the genetical abnormality of AR gene like Candice disease, they do not develop male pattern hair loss. So these are the few points or the basis or the evidences which shows that male pattern hair loss has got a genetic predisposition. Now we come to the next point is the androgen for male pattern hair loss. The testosterone is converted into DHT, that is by an isoenzyme type 1 and type 2 5-alpha reductase. Type 1 is found in sebaceous gland and pilosebaceous gland. Type 2 is found in prostate, dermal papillae, and outer root sheath. Okay, the research data says that the evidences for in favor of androgen is DHT is principal causative agent. AR receptor has got 5 times more affinity to DHT as compared to testosterone. The men with genetic deficiency of 5 alpha reductase type 2, they do not show male pattern hair loss. Balding scalp has high level of 5 alpha reductase than non-balding scalp. So, balding scalp has got higher concentration or higher level of 5 alpha reductase, as well as AR gene expression in balding scalp is more. The pharmacological inhibitors of 5 alpha reductase like finasteride and dutasteride are effective in the treatment of male pattern hair loss on the reversal of miniaturization. Now we come to the female pattern hair loss. It has got androgen base. The androgenetic basis is as strong as male pattern hair loss. It is not so in female pattern hair loss. Again, I am repeating, for female pattern hair loss, the androgen basis is not as strong as it was or it is in male pattern hair loss. The majority of female with female pattern hair loss do not show any androgen abnormality. The women with hyperandrogenism frequently develop female pattern hair loss. There is an inverse relationship of circulating sex hormone globulin and degree of hair loss. Means if circulate free androgen binding protein or globulins are more in concentration, there will be more hair loss. But if they are less in, then the hair loss will be less because the free androgen concentration will be less. Then the enzyme aromatase is found in the scalp of the woman more than in the men. And aromatase inhibitors induces the female pattern hair loss. So the females has got a scalp has got a enzyme aromatase. This enzyme aromatase is a protective for the baldness. But if we use any inhibitor of aromatase, then this may show female pattern hair loss. Now, female pattern hair loss evidence for genetic basis. 54% females with female pattern hair loss has male first degree relative with AGA. 23% of female with female pattern hair loss has a female relative with female pattern hair loss. Means 54% male, 23% females relatives for a patient, for a female patient who is showing the pattern hair loss. Then another important thing is the variation in the gene CYP17 is found to be same in PCOD and male pattern hair loss, indicating that PCOD is female phenotype of male pattern hair loss. The treatment of male and female pattern hair loss treatments are minoxidil, finasteride, dutasteride, low light laser therapy, cell-based therapy, other products, hair transplant, and hair wigs. So we are going to discuss individually for male and female, and we'll see the evidence level or recommendation level. The minoxidil we all know is a chemically 2,6-diamino-4-pyrimethine 1 oxide. The sulfotransferase enzyme which is found in the outer part of the sulfotransferase enzyme which is in the lower part of outer sheath of follicle converts minoxidil to its active metabolite minoxidil sulfate and which stimulates the follicle. This is the effect of minoxidil. This is the steady premature entry of anagen from resting phase. Means if hair follicle is in resting phase, if one is using minoxidil, then there is a early entry of from resting phase to anagen, means the growing phase. It elongates the anagen phase and shortens the telogen phase, controls the thickness of hair and makes hair thicker. does not grow new hair. This is very important, and you must explain to every patient that minoxidil is not going to help them in a bald scalp where there is no miniaturized hair. But if miniaturized hair are there, then it is going to help. More effective in frontal baldness, better effects when combined with finasteride. There is histological evidence and clinical evidence of minoxidil effectiveness. This is the study of the hair weight scale. 5% minoxidil red, then 2% is yellow, one is the placebo, and one is the untreated. So certainly 5% minoxidil shows more result or better result as compared to 2%, and placebo or untreated patient continues to lose their hair or the hair weight. So topical minoxidil for female pattern hair loss evidence-based guideline is they strongly recommend topical minoxidil 2 to 5% solution, 1 ml or half cup of 5% foam twice a day is recommended to improve or to prevent progression of AGA in male patient above 18 years with mild to moderate AGA, means Hamilton Norwood grade 2nd to 5th. We suggest using 5% solution or half cup of 5% foam for greater efficacy, means 5% solution is better than 2%. They suggest response to treatment should be assessed at least at 6 months. If successful, treatment needs to be continued to maintain the efficacy. They recommend for greater efficacy the combination of oral finasteride 1 milligram and topical minoxidil 2 to 5% solution is better choice. We cannot make any recommendation for combination therapy of minoxidil with finasteride or azelaic acid or betamethasone at present time. Further studies are needed to confirm the superiority of the combination therapies consisting of topical minoxidil, diclofenac, tea tree oil, topical minoxidil, azelaic acid, and betamethasone. So, in nutshell, we can say that topical minoxidil 2 to 5% is recommended for male pattern hair loss. 5% is superior than the 2%. It is advisable to apply for twice a day. Foam can be applied once a day. Topical minoxidil for female pattern hair loss. They recommend topical minoxidil 2% solution 1 ml twice a day or half cup of 5% minoxidil topical foam once a day is recommended to improve or to prevent the progression of AG in female above the age of 18 years. They cannot make recommendation for 5% minoxidil foam once daily instead of 2% solution twice daily at present time. Means 5% minoxidil foam once a day instead of 2%. So 2% minoxidil twice a day is better than the 5% minoxidil foam once a day. The response to treatment should be assessed at least at 6 months. If successful, then continuing the minoxidil application. They cannot make recommendation for various combination of minoxidil with others. Now the oral minoxidil 5 milligram per day in man increases hair count but less effective than the topical. Side effects are there: hypertrichosis, pedal edema, and ECG alteration. Then the oral administration of minoxidil is effective. That the Japanese Dermatology Society guidelines says that grade of recommendation is D, means oral administration of minoxidil should not be performed as per the Japanese. Commented no clinical trials have been conducted on the efficacy in oral administration of minoxidil. These were up to the 2018 and they did study up to 2017 only. So this is the 4 years old data. There are few reports on adverse reaction of oral administration of minoxidil other than hypertrichosis, but the post-marketing survey column on the attached document of an orally administered pharmaceutical list serious cardiovascular disorder such as chest pain, tachycardia, palpitation, breathlessness, dyspnea, congestive heart failure, edema, and weight gain has been found. As described above, the benefit and risk of oral therapy with minoxidil have not been sufficiently verified, and it is strongly contraindicated for male and female pattern hair loss as on up to 2017. Finasteride is competitive inhibitors of type 2,5 alpha reductase. Taken orally, it reduces DHT level in serum and in the scalp by up to 70%. So finasteride is not an anti-androgen. This is important that you must explain to the patient that it is not an anti-androgen. It is not going to destroy your testosterone. It does not affect the level of testosterone. It stops only the conversion of testosterone to DHT. What are the effects of finasteride in male? It increases the ratio of anagen to telogen, means number of anagen hair increases than the telogen. Hair weight is increased. Hair weight increases more than the hair count. Better at increasing the growth rate, length and thickness, means it increases more weight, it increases the length of hair, so as count also, but count increases less as compared to length increase and as compared to thickness. Now these are the few studies related to finasteride. This is important to note that randomized trial of 1 milligram finasteride against placebo, 2 years observation showed significantly greater hair counts in the balding vertex than the placebo. 5-year results showed peak from 1 to 2 years but still above baseline for 90% of patients. Let us see one by one. This is global photographic assessment. Finasteride 1 milligram given for 2 years, and they realized 99% of them gained the hair weight or they did not lose the hair. So out of this, 66% gained hair, 33% there was no loss in 2 years, and only 1% lost the hair. Then for 5 years, 48% gained hair, 42% showed no hair loss, and 10% shows the lost hair at the 5 years. Finasteride hair count data, this is showing up to 5 years. Maximum benefit you are getting at the 2 year, then gradually decreases but certainly above than the placebo. Then the hair weight is more than the hair count, and certainly there is an increase. Then there is a steady up to 192 weeks of using the finasteride 1 milligram every day. Then the oral finasteride 1 milligram for male pattern hair loss. What the European says, they recommend oral finasteride 1 milligram recommended to improve or to prevent the progression of AGA in male patient above 18 years with mild to moderate AGA. They recommend the response to the treatment should be assessed at 6 months, although in some men it may not become evident before 12 months. So you must continue therapy with finasteride to decide upon to withdraw it or not, at least a year. They cannot make any recommendation for or against with topical finasteride. Greater efficacy when the combination of finasteride along with minoxidil is given. Finasteride for female pattern hair loss. Oral finasteride is not suggested in the treatment of postmenopausal women with female pattern hair loss. They cannot make any recommendation for or against treatment with oral finasteride 5 milligram a day. So premenopausal women should not be given the finasteride. Also, they are not recommending oral finasteride 1 milligram every day in postmenopausal women for female pattern hair loss. This is a beautiful picture, good study. I took it from Toasty et al. Article, and in 2 years this is the result of finasteride and minoxidil. But after withdrawal of minoxidil and the continuous finasteride for 9 months, the result decreased. So it shows that minoxidil, I think, should be given to each and every patient, and preferably do the combination with finasteride for male. Hair transplant for male pattern hair loss. Surgery, especially follicular unit transplantation, can be considered in male patient with sufficient donor hair. We suggest follicular unit transplantation to be combined with finasteride 1 milligram to achieve a better clinical outcome. Hair transplant for male pattern, European guidelines suggest especially FUT can be considered in female patients with sufficient donor hair. The use of wigs in Japanese society, recommendation use of wig is permissible. Recommendation grade is C1. Although the use of a wig does not improve the symptom of hair loss, its use is permissible when conventional treatment are not successful in improving the symptom. Then the dutasteride. European Society says oral dutasteride 0.5 milligram a day can be considered in case of ineffective previous treatment with 1 milligram finasteride over 12 months as a second line treatment to improve or to prevent progression of AGA in male pattern hair loss after 18 years. Means if you are given finasteride for a year to someone, a patient, and you do not find satisfactory result, then you can switch over to dutasteride. The first line of drug is finasteride. If not getting benefit, then and then only dutasteride. Saw palmitoserano repens, they do not make any recommendation for or against. Then hormonal therapy, they do not recommend the use of estrogen and androgen. They cannot make recommendation for topical alpha triadol. So they are not recommended for the treatment. Hormonal therapy for female pattern hair loss, they do not recommend for premenopausal women. Oral CPA can be considered to prevent progression of age in women with clinical or biochemical evidence of hyperandrogenism, but not to the normal one. They cannot make recommendation for the use of topical alpha thiodol or to improve or to prevent the progression of AGA. So they do not suggest topical hormone therapy should be used to prevent the AGA in female. PRP for male and female pattern hair loss. The European recommendation, there is no standardized technique for performing PRP to permit objective evaluation of its effect on AGA. They cannot make any recommendation for or against of AGA with PRP therapy at present time. This is again 2017 evaluation, 4 years old. They neither said yes or they said no because of various other technical reasons. The factors and cell transplant therapy, Japanese, grade of recommendation C2, introduction of growth factors and cell transplant therapy are not recommended. So they are not recommending. Low light laser therapy, they suggest using low light laser therapy as ancillary therapy for AGA with devices that use energy levels shown in effective and randomized controlled trial. We cannot make a recommendation for or against treatment for more than 6 months low light laser therapy for the treatment of AGA. Means they recommend, but they recommend up to 6 months, but they do not recommend more than 6 months. Then Japanese Society grade of recommendation is B for LLT. Recommendation radiation by light emitting diodes and low level laser is recommended. CQ topical ketoconazole. Topical ketoconazole is permissible. There are weak evidences that suggest the efficacy of topical application of ketoconazole for hair growth for male pattern hair loss. Then the other products, they cannot make any recommendation for or against a treatment with mentioned molecule substances interventions at the present time. These are the various long list of so many things in which they do not make any recommendation for or against. Then the topical bimetoprost and latanoprost, are they effective? What the Japanese study shows, topical bimetoprost and latanoprost are not recommended as on today, means up to 70. These are the few results treated with minoxidil and finasteride. I give finasteride 1 milligram twice a week and minoxidil 5%. These are all the result of minoxidil and finasteride once a week. This is the lady food supplement mainly and minoxidil. This is correction of serum ferritin and minoxidil, minoxidil and ferritin, same patient. So let's sum up the evidence-based guideline for the treatment is finasteride is recommended strongly. Dutasteride after 1 year use of finasteride, if results are not satisfactory, then the dutasteride can be tried. Minoxidil 5% twice a day for the male, once a day for the female, or minoxidil 2% twice a day for the female. Low light laser therapy is recommended. PRP has got neither they recommend nor they refuse. So these are the various recommendations of about the main finasteride, dutasteride, minoxidil. Combination treatment is strongly recommended for male pattern hair loss with minoxidil and finasteride. Low light laser therapy for up to 6 months is recommended. PRP, no opinion for 4 and against. Female pattern hair loss, 2% twice a day shows better efficacy than 5% once a day. Hormone therapy is not recommended. Hormone oral therapy to normal androgen level females are not recommended. Low light laser therapy up to 6 months is recommended. PRP, nor yes or no. So these all were the evidence based studies for and against, giving recommendation and not recommending. So in nutshell, we can say that for male pattern hair loss, combination of finasteride and minoxidil is much superior than using alone. For female, minoxidil 2% twice a day is better than 5% once a day, but because of the user friendly system, females can be advised 5% foam once a day. Hormone therapy for male is not advisable. For female who are having the normal androgen is not advisable. Low light laser therapy you can give for 6 months. PRP, there is no recommendation for or against for this. Thank you. Thank you very much.